everyone. My name is Vivian Oler from the Fred Hutch, and thank you so much for the kind invitation today. I will speak about chronic myeloid leukemia and update in 2022. These are my disclosures. The goals of today's talk are to identify disease-specific risk factors at chronic phase chronic myeloid leukemia diagnosis that influence first-line TKI selection. Secondly, to examine how first-line TKI selection impacts outcomes, including deep molecular response. And lastly, to optimize treatment selection in patients resistant to imatinib and second-generation TKIs. Optimal management in 2022 supports normal life expectancy in most patients. What I show here are data from 1973 to 2013 from the Swedish Cancer Registry, which compared 2,662 CML patients with age-matched peers without CML. As you can see here, life expectancy of CML patients approaches that of the general population. However, optimal management includes eliminating or reducing the risk for CML-related death, preventing or managing irreversible toxicities, and optimizing quality of life by minimizing side effects. I'm going to use a case presentation to illustrate some of the points that I want to make today. So CM is a 58-year-old female diagnosed with CP-CML. The diagnostic peripheral blood BCR-ABL is 91% and E13A2 transcript. Bone marrow cytogenetics showed the T922, but no additional chromosomal abnormalities. Medical history is notable for hypertension, managed with lisinopril, and hyperlipidemia, managed with rosuvastatin. No tobacco use or history of tobacco use, and the SOCL and UTOS long-term survival scores calculate as high risk. There are several CML staging systems for phase. These include the WHO, the International Consensus Classification, the European Leukemia Net, and the MD Anderson criteria. Generally, these have differed in that newer updates for the WHO and ICC have defined accelerated phase as 10 to 19% blasts rather than 15 to 29% blasts as in the ELN or MD Anderson criteria. For WHO and ICC, blast phase includes blasts of 20% or higher versus 30% or higher for ELN and MD Anderson. However, there have been some major changes in the staging classification for WHO as was just published. The WHO has deleted the designation of accelerated phase and labels these as high-risk chronic phase, which is defined as the presence of additional clonal cytogenetic abnormalities or higher blast counts. Blast phase is still defined as 20% or more blasts. Although this classification is in keeping with how we view CML progression biologically and mechanistically, this really does make the job of the clinician prescribing TKIs a bit more complicated. For clinical outcomes associated with TKI use, almost all of our clinical trials have used the MD Anderson or ELN criteria to define phase at trial enrollment, and these data continue to inform patient outcomes even as AP and blast phase definitions continue to evolve. I will review some of the data that contributed to outlining the relevance of additional clonal chromosomal abnormalities on outcomes. There has been some debate regarding the specific high-risk additional cytogenetic abnormalities, or ACAs, as I'm going to refer to them. Nonetheless, ELN defines these as major route ACAs, which are more frequently observed in blast phase, and these include trisomy 8, an additional Philadelphia chromosome, isochrome 17, and trisomies 19, 21, and 17. The minor route ACAs include rearrangements of 3q26.2, L11q23, and monosomy or deletion 7. Complex karyotypes are also associated with poor outcomes. Shown here at left are the data from the German CML study 4 of patients treated with imatinib. In this retrospective review, they looked at 1,510 evaluable patients, of which 123 had ACAs. And this is actually in keeping with other reports where ACAs were found in about 3 to 7% of patients at CML diagnosis. In this retrospective review, among high-risk ACA patients, 37 patients died, with 32 of 37 dying from CML-related causes. Among the 54 living patients, 5 died of disease, 5 had disease progression. This contrasts with low-risk ACA group, as you can see here. These data and others have consistently demonstrated that high-risk ACAs are a marker of progression and death due to CML, and consequently, these patients are at risk even with low blast counts. Our patient, CM, has no ACAs. In addition to ACAs, there are some other features that are associated with poor outcomes. High clinical risk scores, including the SOCAL, EROS, and the ELTS score, are associated with poor overall survival. Published data also supports that the P190 associated transcript E1A2, which is rarely seen in chronic phase CML, is also associated with poor outcomes. Recent studies have also observed that patients with E13A2 transcripts have lower rates of deep molecular response on either imatinib or nilotinib. What is likely not prognostic in the era of TKIs is deletion of derivative 9 chromosome, most variant translocations, and most likely other rare transcript variants, although these rare transcript variants are much harder to monitor due to dedicated sensitive qPSC-R assays. So outside of the research setting, we don't have deep molecular monitoring assays for these. There is a new CML risk score, and this is recommended by ELN at diagnosis. This risk score includes the same variables as the SOCAL score: age, spleen size below the costal margin, peripheral blood blasts, and platelet count. However, in comparison to the SOCAL score, the variables are actually weighted differently. So what I show here is a recent publication by Dr. Furman and colleagues in which the ELTS score was used retrospectively to look at 5,154 patients treated with imatinib. Our patient has a high-risk ELTS score, which is shown in black and is associated with a higher risk of dying due to CML. Retrospective comparisons support that the ELTS score is better at identifying patients at risk for dying of CML. It also classifies fewer patients as having high-risk CML. There was also a recent publication by Dr. Zhang and colleagues that's described that the ELTS score may also be a better predictor of deeper molecular responses and CML-related survival, particularly in those patients who receive second-generation TKIs. In the US and the EU, we currently have 4 ATP-competitive tyrosine kinase inhibitors in the frontline: imatinib and the second-generation TKIs, dasatinib, nilotinib, and bosutinib. Ponatinib is approved in the US for T315I mutated CML and also in the third line and beyond. The US FDA has just approved the novel myristoyl pocket inhibitor asciminib for intolerance or resistance of 2 or more TKIs for CP-CML with the T315I mutation. The protein synthesis inhibitor maxitosine is also approved in the US in the third line and beyond. The table here was created and updated with the assistance of Dr. Malhotra earlier this year. And so I know that imatinib, dasatinib, and bosutinib are available in India as generics, and nilotinib is available as branded to Cigna. Although ponatinib is an important treatment option for resistant and intolerant CML in the US and the EU, ponatinib is not readily available in India. However, asciminib is available through a compassionate use access program. With the availability of inexpensive second-gen TKIs, the use of second-gen TKIs is also increasing, I've been told. I'd like to briefly review CML treatment milestones before proceeding too much further. So after therapy is started, BCR-ABL1 transcript levels are monitored in the peripheral blood. As shown here at left, the responses that are associated with substantial benefits in progression-free and overall survival are BCR-ABL1 of less than 1%, or the molecular equivalent of a complete cytogenetic response. Shown at right are the responses that you need for patients to be candidates for consideration for TKI discontinuation. And these include the deeper molecular responses such as MR4, which is a BCR-ABL of less than or equal to 0.01%, and MR4.5, which is a BCR-ABL of less than or equal to 0.0032%. So back to our case. For CM, his ELTS score, her ELTS score is high risk. Additionally, past medical history is notable for hypertension and hyperlipidemia. There are common side effects for all the TKIs, as well as unique toxicities for each of the individual TKIs. So common side effects are myelosuppression, rash, and fatigue. For imatinib, we see peripheral edema and periorbital edema, myalgia, and nausea fairly commonly. For bosutinib, diarrhea and nausea are common, especially early in the treatment course. For dasatinib, pleural effusion occurs more frequently, And for nilotinib, there is an increased risk for arterial occlusive events, which include cardiovascular, cerebrovascular, and peripheral arteriovascular events. A retrospective study from Australia that looked at 220 patients treated with nilotinib at 17 centers, as well as some other data that we have from other studies, have indicated that the cumulative incidence of arteriovascular events is on the order of 10 to 20%. In this particular review, events were more common in older patients, especially those with a smoking history or a history of dyslipidemia. What was really important and relevant to my own practice is that there was a very high rate of recurrence if you continued nilotinib even after you did the appropriate medical management. Pleural effusion, we know, is a significant risk with dasatinib. This is a pooled analysis of 11 trials that estimated the annual risk is between 5 to 15%. Notably, pleural effusion can occur at any time in treatment. At 5 years for patients treated frontline with dasatinib on the DECISION study, 28% in pleural effusion, and at 7 years for patients on the second line dose optimization studies, the incidence was 33%. We also know that the risk increases with age, and up to 50% of patients 60 years or older can develop pleural effusion on the 100 milligram dose. And this is why consideration for a lower dose of 50 milligrams is recommended. So what data do we have to support using lower doses frontline? A pilot study from MD Anderson, now with longer follow-up at 2 years, has supported the efficacy and improved safety profile of dasatinib at 50 milligrams daily. In this pilot study, they looked at 81 patients treated frontline with dasatinib at 50 milligrams, and they compared these patients to a historical cohort treated at 100 milligrams or imatinib treated. So you can see here in dark blue that there were excellent molecular responses observed in the 50 milligram dose group, with 81% of these patients achieving major molecular response at 12 months. Furthermore, pleural effusion occurred less frequently and was observed in 6% of patients. Additionally, very recently, a manuscript by Murai and colleagues from the Japanese DAVLEC study also support the efficacy and safety of a very low dose of dasatinib in elderly patients. This was a multi-center, single-arm phase 2 study at 25 Japanese hospitals. The study enrolled patients older than 70 with a median age of 77. Patients received dasatinib frontline at 20 milligrams per day. The estimated complete cytogenetic response at 12 months was 85%. Major molecular response was 60%, and they also saw deeper molecular responses. Among 31 of the 52 patients who achieved major molecular response, 74 did so without a dose escalation. Adverse events were low grade typically and occurred in 73% of patients, and pleural effusion was seen in only 4 of these patients and was only grade 1 to 2 and not higher. Dasatinib is also associated with pulmonary arterial hypertension. In a retrospective review of 41 cases confirmed by right heart catheterization, there wasn't a clear relationship to dose established. It also can occur at any time during treatment. Notably, in this retrospective review, 68% of these patients presented with asynchronous pleural effusion, and thus we recommend an echocardiogram to assess for PAH when you see an effusion. Fortunately, if caught in time and dasatinib is discontinued, PAH will resolve slowly in most patients and was 94% in this study. So in summary, when considering a second generation TKI, as was outlined by Dr. Cortez in his 2020 ASH education session chapter, specific comorbidities may make some second generation TKIs less preferred. So for example, nilotinib is less preferred in patients with diabetes, cardiovascular or peripheral arterial disease. Dasatinib is less preferred in patients with pulmonary disease, PAH or cardiovascular disease, and bosutinib is less preferred in patients with liver or renal comorbidities. The NCCN guidelines suggest consideration for a second generation TKI frontline in patients with higher risk score CP-CML, and I'd like to spend some time discussing the data that went into that recommendation. The INEST-ND study was a randomized study frontline of imatinib versus 2 doses of nilotinib. Shown here are 5 years follow-up, and you can see the number of patients with CML disease progression to accelerated phase or blast pit phase is higher in patients receiving imatinib versus nilotinib. This was 10 cases for nilotinib at 300 milligrams twice daily versus 6 cases for nilotinib at 400 milligrams twice daily versus 21 cases for imatinib at 400 milligrams daily. Relevant to our patient, as I show here in the red box, there were fewer cases of disease progression among patients with high-risk SOCAL score who received nilotinib versus imatinib, although I will note that the study wasn't specifically designed to answer this question. The BEFORE study was an open-label, randomized, multi-center phase 3 study that randomized patients to bosutinib at 400 milligrams daily versus imatinib at 400 milligrams daily. The primary endpoint for this study was the rate of major molecular response at 12 months. And Dr. Brummendorf presented 5-year updates to the outcomes of the BEFORE study at the ASH annual meeting in 2020. At 5 years follow-up, bosutinib demonstrated continued higher cumulative molecular responses, including deeper molecular responses that we need for TKI discontinuation consideration, with 58.2% of bosutinib-treated patients achieving MR4 and 47.4% achieving MR4.5 by 5 years. We also have similar data for dasatinib and nilotinib versus imatinib. At the European Hematology Association annual meeting very recently in 2022, Dr. Deininger and colleagues reported on the impact of dose reduction on outcomes for patients treated on the BEFORE study. So notably, 43% of bosutinib-treated patients versus 19% of imatinib-treated patients had to reduce dose for treatment-emergent adverse events. For bosutinib-treated patients, these are generally GI side effects such as diarrhea. After dose reduction to 300 milligram daily, 62.2% of the bosutinib patients and 64% of the imatinib-treated patients achieved or maintained a major molecular response for at least 6 months or longer after a dose reduction. Among bosutinib-treated patients reduced to 200 milligrams, which was allowed, these patients, 36.4% achieved and maintained major molecular response. Consequently, these data also support that dose reduction can improve tolerability and maintain efficacy, although this needs to be monitored very carefully. So back to our patient. So in addition to a high-risk ELTS score and comorbidities, the patient also noted that she prioritizes becoming a candidate for TKI discontinuation very highly. So the benefits of TKI discontinuation include resolution of TKI-related side effects and mitigation of long-term iatrogenic risks. Patients also feel cured. Lastly, it can reduce out-of-pocket medical costs to patients and the financial burden of CML treatment on healthcare systems. However, although TKI discontinuation is an important goal, as shown by the green arrow and the green box, many patients remain on TKI therapy longer term, if not lifelong, and thus quality of life on TKI therapy is very important. One of the earliest imatinib discontinuation studies was STIM-1 in France. This was a study of 128 patients who discontinued imatinib. The first patient discontinued therapy in 2004. The median duration of imatinib prior to discontinuation was 7 years, and the median duration of MR4 prior to discontinuation was 4 years. Molecular recurrence was defined as the loss of major molecular response, and the primary outcome measure shown here is treatment-free remission without molecular recurrence, which is shown here in red. The TFR rate recently updated at 7 years was 45.6%. Other larger imatinib discontinuation studies have included STIM-1, STIM-2, Australian Twister, Euroski, and the Korean Kids study. Similar results have also been reported for patients stopping second-generation TKIs across various groups, including our own study, the US last study. Overall, the success rates of TFR attempts in clinical trials have ranged between 40 to 65% and have been quite consistent, even with varying entry criteria, such as the duration of TKIs before discontinuation and specific molecular responses and depth of responses. So what variables are associated with successful TFR? The prospective Euroski study was a study of imatinib discontinuation after at least 3 years of treatment and 1 year of MR4. So during a pre-specified interim analysis, it was found that longer duration of TKI, and in particular, longer duration of deep molecular response, was associated positively with sustained treatment-free remission. What was less predictive in this particular study was the depth of response, such as MR4 versus MR5, 4.5, and its impact on sustained TFR. The US Life After Stopping TKIs, or the last study, enrolled 172 patients at 14 US sites. For patients on TKI therapy for at least 2 years, with 2 years of MR4, we allowed patients to discontinue imatinib, nilotinib, dasatinib, or bosutinib, and 65.5% remained in major molecular response at 3 years, and our TFR rate was 60.8%. On this study, we also assessed BCR-ABL transcripts using 2 approaches: the standard real-time qPCR assay, which we use clinically, and a more sensitive droplet digital PCR approach. ddPCR offers about a 0.5 to a 1 log increase in sensitivity in BCR-ABL transcript detection. This effect is because of partitioning that increases the effective concentration of single copies by decreasing the background. As shown here in the red box, for patients with undetectable BCR-ABL by both RQ-PCR and digital droplet PCR, molecular recurrence was the lowest at 10.3%. These data, together with data from other groups, do support that the depth of response likely also impacts sustained treatment-free remission. It's based on these observations, as well as other observations, that the NCCN and the European Leukemia Net have made recommendations for TKI discontinuation. The minimal criteria, which are endorsed by ELN and NCCN, include at least 3 years of TKI treatment and at least 2 years of MR4 or better. However, the ELN also provides some guidance on optimal TKI discontinuation criteria, and these include at least 5 years of TKI therapy and at least 3 years of MR4 or 2 years of MR4.5. Molecular recurrence occurs most frequently early after discontinuation, and in the STIM1 with longer follow-up of imatinib discontinuation, 51% of patients had molecular recurrence off of therapy. Generally, about 85% of molecular recurrence occurs within the first year of discontinuation, which is why the NCCN recommends that you monitor monthly for 6 months, and then every 2 months for months 7 through 12, and then every 3 months indefinitely. Most patients will regain deep molecular responses within about 4 to 7 months after restarting therapy. And as shown however, there are also patients with late relapses. So on STIM1, this was 14% of patients, and you can see here that they reported relapses as late as 6.4 years after stopping, and this is why lifelong monitoring is recommended. Are there any risks associated with TKI discontinuation? Generally, there are very few risks. Loss of TKI sensitivity upon TFR failure or CML progression are exceptionally rare. However, TKI withdrawal syndrome does occur in patients. So what is TKI withdrawal? So this has been reported in about 25 to 30% of patients and is characterized by low-grade musculoskeletal pain. In the Korean imatinib discontinuation study, kids, the median duration was 6 months, but the range included up to 36 months. Variables associated with an increased risk for withdrawal syndrome included a longer duration of TKI use and a prior history of osteoarticular symptoms. I have in my own practice favored a dose reduction strategy prior to TKI discontinuation. As I noted from the before study data that a few slides ago, these and other retrospective data do support that patients can maintain responses with dose reduction, particularly for patients for major molecular response or deeper, although one has to monitor very carefully. So what I show here are prospective data from the UK DESTINY study, where patients with a durable major molecular response or MR4 were able to decrease TKI dose by 50%. And this included imatinib, dasatinib, and nilotinib, although I will say the majority of patients here were imatinib treated. So for imatinib dose reduction, this was down to 200 milligrams. Among patients with MR4, only 3 patients or 2% lost MR4, and among patients with MMR, 19% lost major molecular response. Patients were eligible to then discontinue TKI therapy if they maintained MMR or deeper molecular responses for at least a year. For the MR4 group, 72% remain in treatment-free remission 3 years after study entry, which is 2 years after TKI discontinuation. Notably, patients also had an improvement in adverse side effects. Although we don't have clear data that this approach of dose reduction mitigates TKI withdrawal syndromes, I find that it can uncover patients who fail TKI discontinuation, and I remain hopeful that this approach actually helps patients have less TKI discontinuation withdrawal symptoms. So you might wonder how it's possible that somebody could have detectable BCR-ABL and still remain in TFR while another patient doesn't. We have learned that patients with deep molecular responses probably have a different immune microenvironment as compared to patients at CML diagnosis. And so among studies, I show here a recent study for the Australian Australia-Asian Leukemia and Lymphoma group, which looked at patients on TKI shortly before they stopped therapy on the CML8 Twister study. And the authors reported here that patients with successful treatment-free remission had increased NK cells with an activating receptor expression, and also had decreased regulatory T cells and decreased monocytic myeloid-derived suppressor cells. Other studies have reported similar findings. So it is possible that at some point in the future, we'll have an immune cell signature to predict successful TKI discontinuation. So back to our patient. So based on this discussion with the patient who has a high-risk ELTS score and SOCL score, who also prioritized achieving a deep molecular response as quickly as possible, bosutinib was started at 400 milligrams daily. So reviewing the side effects with the patient, as shown here for the before study with longer follow-up, GI side effects, in particular diarrhea and nausea, are quite common, although these are typically grade 1 and grade 2. Liver side effects include an elevated AST and ALT are also common. However, as shown here by the red box and the arrow, pleural effusion and also arterial occlusive events are rare. In my own practice, I will consider starting a lower dose of bosutinib in patients and escalating for response, which sometimes helps to mitigate early GI side effects, which typically contribute to discontinuation. So do we have any data for this? I've shown you outcomes for dose reduction for frontline before study of bosutinib versus imatinib, but there are some recent data regarding outcomes for patients who start lower doses of bosutinib in the Italian BEST study. So this was a study of older CML patients, 60 years or older, who started bosutinib in the second line. Most had previously been treated with imatinib frontline, 83%. The primary endpoint here was major molecular response at 1 year. Patients were started on 200 milligrams daily and then increased after 2 weeks to 300 milligrams daily. Bosutinib was then increased further after 3 months based on molecular response, specifically increasing to 400 milligrams if the BCR-ABL was greater than 1% in the absence of toxicities. Follow-up is now available and was reported in an abstract presentation this year. And at 3 years at the EHA meeting in June, they reported that at 36 months, 57% are still on bosutinib. And notably among this group, 94% remain on the 300 milligram or 200 milligram dose. As shown in the figure, 78% of the patients have major molecular response, with higher rates in the intolerant patients, as you might expect, and MR4 was seen in 54% of patients. So our patient was treated with bosutinib at 400 milligrams daily. BCR-ABL at 3 months was 35%. Our patient struggles with adherence. Our patient is adherent to therapy, but struggles with fatigue. We managed aggressively with antidiarrheal medications for the first 2 months. And these, as I've seen in my own practice, improved after week 10 on therapy with some diet modifications. BCR-ABL transcripts at 6 months, however, were 29%. So the NCCN summarizes response milestones. And so BCR-ABL of greater than 10% at 6 months is considered resistance. And we recommend assessment for mutations in ABL and consideration for alternative therapy. In addition to early molecular responses, we would like patients to achieve a BCR-ABL of less than 1% by 12 months, because this is associated with long-term survival benefits and better progression-free survival. For some patients, as shown here in the light green, who are unable to achieve deeper responses without substantial toxicity, results between 0.1% and 0.9% can be acceptable because of the survival benefit. However, and as shown in the dark green color, achievement of major molecular response and subsequently deeper molecular responses are required if the treatment goal is treatment-free remission. The importance of early molecular response has been demonstrated across multiple retrospective studies of imatinib and second-generation TKIs. I show here results from the DECISION study, which randomized patients to imatinib or dasatinib frontline. As you can see at left, patients on second-generation TKIs such as dasatinib are more likely to achieve an early molecular response. Early molecular response, or a BCR of less than 10%, was achieved in 84% of dasatinib-treated patients versus 64% of imatinib-treated patients. However, as you can also see, outcomes are similar for patients who achieve this milestone, whether you receive imatinib or dasatinib. Additionally, 3 months may be too early to assess for some patients who receive imatinib or have their treatment interrupted frequently for intolerance or adherence issues. For this reason, NCCN recommends 6 months. However, I will say caution is warranted in patients receiving frontline second-generation TKIs who are adherent to therapy. As shown in the figure at the bottom left, mutations for the most part cluster in the P loop or the activation loop of ABL. For patients who do harbor mutations, the NCCN guidelines do provide some recommendations on which TKIs you should avoid based on mutation status. And this comes from in vitro data as well as patient data from clinical trials. For example, patients with a V299L mutation, bosutinib and dasatinib should be avoided, but nilotinib is a reasonable choice. The T315I mutation confers resistance to imatinib, bosutinib, and dasatinib, and nilotinib, and only is treated by ponatinib or asciminib. Relevant to our patient, not all resistance is mutation-driven. Mechanisms include BCR-ABL-independent mechanisms of resistance. Additionally, as described for imatinib, alterations in specific drug transporters such as OCT1 can influence response. Overall resistance in the absence of mutations is not well defined, and as many of us have recognized, is quite a bit harder to treat. Question that I'm frequently asked in my practice is whether the mutations that I see described in AML or MDS impact CML therapy responses and risk for disease progression. Earlier work sequencing CML patients by next-gen sequencing in all phases of disease has identified, as I show here in red, that mutations are rare at the time of diagnosis of CP-CML. But as you can see in blue, they are more common with disease progression to AP or blast phase. The most common mutations described in CP-CML are ASXL1, and in AP and BP are RUNX1, BCOR, and GATA2 mutations. Our patient harbors an ASXL1 mutation identified by NGS. Specifically, this was a duplication of a guanine nucleotide that leads to a frame shift. Dr. Sean Muganathan and colleagues from Australia presented these data in abstract format in 2020 that I show at right. They also just published this. They used an RNA capture panel to look at 160 patients. And they looked at mutational events that were not only cancer-associated gene mutations, but also included what we call Philadelphia-associated changes, including cryptic fusions or inversions of BCR-ABL. As you see here in red, CP patients who had mutations were more likely to have CML disease progression to AP or blast phase versus those without mutational events. However, I will say generally we have limited prognostic information on the outcome of patients with CP-CML and the impact of mutations on those outcomes. For this reason, although specific mutations such as ASXL1 and RUNX1 may be associated with response to date where NGS is available, and you do it, we don't provide clear recommendations on how to use these data in treatment selection. I will say that the acquisition of high-risk additional cytogenetic abnormalities is more worrisome and is clearly associated with disease progression, as I showed earlier in my talk. So what data do we have regarding response to second-line therapy after imatinib? So for patients who fail imatinib, we see lower rates of CCYR or BCR-ABL of less than 1% in patients who are resistant to imatinib versus those who are intolerant. Across studies, CCYR was seen in about 40 to 45% of imatinib-resistant patients versus 55 to 65% of imatinib-intolerant patients. The results of the phase 4 Beyond study were published in 2020. The purpose of this phase 4 study was to provide further safety and efficacy data for bosutinib in the management of CML-resistant or intolerant to prior TKIs, including second-generation TKIs, nilotinib and dasatinib. I think these data are important in places where we don't have access to ponatinib or asciminib easily because bosutinib may be a choice in this situation. The primary endpoints included confirmed major cytogenetic response by 1 year and dose reductions to 400, 300, or 200 daily due to toxicity and tolerability were permitted. The impact of line of therapy on major cytogenetic response, which includes complete and partial cytogenetic response, I show here in the red box. And as you might expect, shows diminishing response with line of therapy. So major cytogenetic response was 80% second line, 60% third line, and 41.7% fourth line. Overall, I will say that patients who fail second-generation TKIs are a difficult group to treat, especially those patients who have resistance without mutations. So these are data from a meta-analysis by Dr. Lipton and colleagues that show response to another second-generation TKI third line to another second-generation TKI or to ponatinib. So the endpoint here examined was a complete cytogenetic response, which is the equivalent of BCR-ABL transcripts less than 1%. So as you can see here, the proportion of patients achieving a CCYR on another second generation after having received a second generation is lower. It's about 25 to 30%, which is different than what was reported in the phase 2 PACE study of ponatinib, where 50 to 60% of patients achieved a CCYR. However, ponatinib is associated with a significant arterial occlusive event risk and consequently requires close monitoring when we are using this drug. In the PACE phase 2 study, 26% of patients were reported to have experienced an arterial occlusive event, of which 15%, 7%, and 11% were cardiovascular, cerebrovascular, and peripheral vascular arterial occlusive events. So back to our case. Our patient received dasatinib second line at 100 milligrams orally daily. BCR-ABL transcripts at 8 months were 32%. Patient was fully adherent to therapy. No mutations in ABL were detected when measured again, and BCR-ABL transcripts at 9 months were still elevated at 30%. So in the last part of my talk, I'm going to discuss 2 treatment options available in the US in the third line or beyond, and for T315I mutated CPCML, specifically ponatinib and asciminib. So although I know ponatinib is not available, I do want to review the recently published data supporting new ponatinib dosing recommendations in chronic phase CML. And this was the phase 2 OPTIC trial of ponatinib, which was a trial that was designed to determine the optimal ponatinib dose to maintain efficacy, but minimize arterial occlusive events. The OPTIC study enrolled 283 CPCML patients resistant or intolerant to 2 or more TKIs with BCR-ABL greater than 1% at study enrollment. More than 50% of these patients had received 3 or more TKIs, and 90% were resistant to their last TKI. Patients were randomized 1:1:1 to 15 milligrams, 30 milligrams, or 45 milligrams. Notably, for patients receiving 30 and 45 milligrams, there was a mandatory dose reduction to 15 milligrams once BCR-ABL was less than or equal to 1%. This was built into the study to minimize the risk for arterial occlusive events, and the primary endpoint was BCR-ABL of less than or equal to 1% at 12 months. The efficacy and safety of each of the OPTIC cohorts is shown here in this figure, and the efficacy rate is shown in light blue, and treatment emergent arterial occlusive events that were adjudicated by cardiologists is shown in the medium blue color. You can see here, starting at 45 milligram dose and then reducing to 15 milligrams was associated with the greatest efficacy. It was twice as high on the 45 milligram dose, with 51.6% of patients achieving BCR-ABL of less than or equal to 1% by 12 months, as compared to patients on the 15 milligram starting dose. Arterial occlusive events were still dose related, but this strategy of early dose reduction, as shown here, does appear to mitigate This risk with a lower incidence relative to what was observed in the phase 2 study, which I reported on the last slides, which did not include a response-based dose reduction strategy. And so for OPTIC, this is currently 9.6% in the 4.5 milligram, 45 milligram starting cohort. Subgroup analysis also focused on various groups of patients, including patients with a T315I mutation, as well as patients with other mutations or no mutations. As you can see here in light blue, higher doses of ponatinib are particularly important for patients with T315I mutations. Fewer patients receiving the 15 and 30 milligram dose achieved BCR-ABL of less than 1%. Asciminib is a new treatment option available in the US and on compassionate use in India. So asciminib is not a TKI, binds to the myristyl pocket of ABL rather than the ATP binding site and ultimately blocks its function this way. It's highly selective with a narrow target profile. It's active against mutations that confer resistance to TKIs, including the T315I. Initial safety, efficacy, and tolerability were demonstrated in the phase 1 study published in the New England Journal of Medicine in 2019. The results of the ASSEMBLE study were published in 2021 in Blood and led to the FDA approval of this drug in the US. The ASSEMBLE study was a phase 3 study, randomized, that looked at 233 CPCML with resistance or intolerance to 2 or more TKIs. Patients with the T315I or the V299L mutation were excluded as bosutinib can't treat these mutations. Patients were randomized 2-to-1 to asciminib at 40 milligrams twice daily or bosutinib at 500 milligrams daily. And the primary endpoint was major molecular response at 24 weeks. For the most part, the treatment arms were well balanced, except there were more patients in the bosutinib arm who had discontinued their last TKI due to efficacy. Additionally, there were somewhat more patients on the bosutinib arm who had received 3 or more TKIs. Shown here at left is complete cytogenetic response rate at 24 weeks, and at right, the major molecular response rate at 24 weeks. Data were adjusted for major cytogenetic response status at baseline. CCYR was 40.8% for asciminib-treated patients versus 24.2% for bosutinib-treated patients. With regard to the primary endpoint, major molecular response at 24 weeks, MMR was 25.5% in asciminib-treated patients versus 13.2% in bosutinib-treated patients. These data have been updated at ASH in December of last year and also just updated at ASCO this June, and continue to demonstrate a higher cumulative incidence of MMR at weeks 48 and 96 in asciminib-treated patients. Specifically, at week 48, MMR was 33.2 in asciminib-treated patients versus 18.6% in bosutinib-treated patients. By week 96, 53.5% of asciminib-treated patients remain on treatment versus only 19.7% of bosutinib-treated patients. This high discontinuation rate in the bosutinib arm really does limit further comparisons. Nonetheless, MMR rate at 96 weeks was 37.6% in asciminib-treated patients versus 15.8% in bosutinib-treated patients. Notably, durable responses were seen in this group, with 96.7% maintaining MMR on asciminib and 93% on bosutinib. Asciminib was also well tolerated. The most common AEs on asciminib include hematologic toxicity such as thrombocytopenia, and other side effects such as diarrhea, nausea, rash, and transaminitis were pretty rare. In keeping with published data of bosutinib and data I've shown you today, GI side effects were common in bosutinib-treated patients. Important data that resulted in asciminib approval in the US for T315I mutated CML came from the phase 1 study. The dose of asciminib needed here to inhibit T315I mutated CML is significantly higher. The dose we need to use is 200 milligrams twice daily. About half of this small group of patients achieved major molecular response, which was durable in most. As I show you here by the black curve, the cumulative incidence of MMR was higher in ponatinib naive patients versus ponatinib pretreated patients, and was 57.8% in naive versus 28.6% in resistant patients. However, I will say there is some caution is warranted, as there is new real-world data emerging that patients with limited response to ponatinib subsequently don't have a very good response to asciminib. There are some important caveats and limitations to this study. Was bosutinib really the best comparator arm for patients failing a prior second-gen TKI, as I alluded to earlier in my talk? Ponatinib may have been a reasonable comparator. Additionally, there were high discontinuation rates for bosutinib arm versus what we had seen in other bosutinib treatment studies. What remains unclear to me is whether highly resistant patients without mutations, if asciminib is truly non-inferior to ponatinib. And lastly, although so far the data do support a low arterial occlusive event signal, it's not entirely clear if there will be an AOE signal after we have longer follow-up. There are also some novel therapies under evaluation at ASH. Last December, updated data for the vodobatinib study was reported, as well as for olverembatinib. And there are actually going to be 3 olverembatinib study presentations at ASH this year, including one that I'm participating in the third line and beyond. Vodobatinib is a selective oral inhibitor of BCR-ABL, but it's not effective against T315I. Phase 1 data supports well tolerated and clinical benefit has been observed. Updates for the olverembatinib that were presented last year suggest that this has good activity, including T315I. Updates for 101 CP and AP-CML patients in China was reported with a complete cytogenetic response seen in 69% and major molecular response in 54% of resistant CP-CML patients. So, CM started ponatinib 45 milligrams daily and reduced to 15 milligrams daily once BCR-ABL was less than 1%. This dosing was followed as part of the OPTIC study and the new US FDA labeling. But the brother was identified as a 10 out of 10 HLA allele match for HCT. However, our patient achieved a major molecular response after 3 months of ponatinib and subsequently deeper responses after 9 months, and continues on ponatinib, and transplant was not proceeded and did not follow. So when do I consider allogeneic transplant? It is really important, given this patient's response, to remember HCT. Generally, I consider typing after failure of second-line therapy before I initiate third-line therapy, and rarely in some patients, especially those worrisome patients who failed frontline second-generation TKI without mutations, I might actually type earlier. I think about transplant in patients always with progression to accelerated phase or blast phase, as well as in de novo blast phase patients. A remission to second chronic phase can be induced by TKI or TKI in combination with chemotherapy based on the lineage of the blast phase. I will say there's data from MD Anderson that supports TKI plus chemotherapy is more effective in this strategy. For de novo AP patients, there is a group of patients who will respond to frontline TKI therapy, and thus I will type and monitor closely to see that they achieve optimal responses. However, I recommend HCT for all de novo AP patients and AP patients with progression with worrisome ACAs, such as complex karyotype and some of the ones that I showed earlier in this talk. So what are this data supporting the subset of frontline de novo AP patients respond to TKI therapy? So there are a couple of sources of these data, but I'm showing here MD Anderson data of 51 patients. As you can see here with the arrows, for de novo AP patients who presented with AP receiving frontline therapy, 84% achieved complete cytogenetic response and 69% major molecular response. Notably, if you achieved a complete cytogenetic response, overall survival and event-free survival were excellent at 100% and 96% respectively. However, again, this really requires careful following and management because ACAs such as inversion 3, monosomy 7, and complex karyotype are highly associated with disease progression. So I recommend transplant for these patients. I will say, though, we don't see as many of these high-risk ACAs in de novo AP as compared to patients who develop AP on TKI therapy. So in contrast to the de novo AP data I just showed you, what I show here in the red box are the not very good outcomes on second and third generation TKIs after progression to AP. And this is why HCT is recommended. The data regarding survival after HCT for CML are shown here from the Center for International Blood and Bone Marrow Transplant Research for CML transplants between 2007 and 2017. These data include 1,360 patients with a matched sibling donor and 1,682 patients with an unrelated donor. As you can see here, outcomes are similar for match-related and unrelated donors. Importantly, you can see that phase is a strong predictor of outcomes, with overall survival at 3 years of 61% for matched unrelated donors, declining to 49% for accelerated phase and 33% for blast phase. Thus, the timing of transplant before progression is critical. Based on age in the US, many of our patients are candidates for reduced intensity conditioning transplant. I show data here from a recent paper by Chabra and colleagues, which looked at 1,395 allogeneic transplants for patients between the ages of 18 and 60 who were either in CP1 or a return to CP from advanced phase called CP2 or accelerated phase. 1,204 patients received myeloablative conditioning and 191 received reduced intensity conditioning. The red solid line is myeloablative and the blue dotted line is reduced intensity conditioning. As you can see here, there wasn't a significant difference in non-relapse mortality, relapse, leukemia-free survival, or overall survival in multivariable analyses. However, I direct you to the top right of the figure. You can see there is a higher risk for early relapse with reduced intensity conditioning, which is demonstrated by the separation of curves early on. So in conclusion, I use a patient-oriented and care provider-directed framework to guide first-line TKI therapy selection and CP-CML based on current evidence. I do favor second-generation TKIs in high-risk ELTS score patients and patients with advanced phase CML. I carefully discuss the risks versus the benefits of a second-gen TKI in patients who strongly prioritize TKI discontinuation, especially in female patients who have family planning ahead of them. Imatinib by far remains a very safe drug with excellent long-term follow-up, and I use it in many of my older patients with comorbidities. Treatment-free remission is an important goal for many patients, but many don't achieve durable deep molecular responses or fail TKI discontinuation. So long-term quality of life on TKI therapy is very important. Third-generation TKIs or asciminib are more likely to result in BCR of less than 1% or major molecular response in patients resistant to a second-gen TKI without specific mutations. Ponatinib is preferred by the ELN. Asciminib, novel agents, and combinations are under evaluation in clinical trial, but don't forget transplant for eligible CP-CML patients in the third line and beyond who aren't responding. And thank you so much for your attention today, and thank you again for the kind invitation, and I'm happy to answer any questions.
So Dr. Vivian, good evening. It is an excellent talk. I just introduce her formally. He's Associate Professor of the Clinical Research Division at Fred Hutchinson Center and in the Division of Hematology at University of Washington School of Medicine. She's also a practicing physician at the Seattle Cancer Care Alliance. At the SCCA, she sees patients with chronic myeloid leukemia, acute myeloid leukemia, and myeloproliferative neoplasm. And her translational research explores mechanisms that contribute to disease progression and therapy resistance in these diseases, and is examining new therapies in the treatment of CML and AML through an active portfolio of clinical trials. She has authored more than 50 peer-reviewed articles and served as principal investigator for over 30 active or past research grants. She's a member of the American Society of Hematology and the Southwest Oncology Group, and served as the NCCN Chronic Myeloid Leukemia panel. So Dr. Vivian, so we have a couple of hematologists and medical oncologists on the board, and there are some audience also. So I just have the question from my side that when you discuss any patients about TFR, what is the point you discuss in the TFR in the clinic? What are the practical points you talk with them?
Oh, you mean to discuss it early on versus later?
Yeah.
Well, I actually raise this issue because many patients come to see me with this idea based on reading on Dr. Google that they're going to be eligible for TKI discontinuation. And so I do raise it early on the treatment course, but I agree, since it's going to be at least 5 or 6 years until someone's going to be eligible for it, it might not be the thing to focus on most of that conversation at diagnosis. But the European Leukemia Net has, in several publications, endorsed consideration for deep molecular response as being a reasonable goal for many of our patients. For me personally, I agree with what we have written for NCCN, and I think early on with our experience with CML, we really did push for deeper responses, but having learned a lot about the toxicities longer term of some of the second generation drugs and other drugs, and recognition that the prolongation of life really comes with BCR-ABL of less than 1%, 0.1%. We don't have to push patients to deep molecular response. However, if you don't get a deep molecular response, you will never be eligible for TKI discontinuation. And I see a lot of younger patients in my clinic, and in these scenarios, I do favor second generation TKIs, recognizing that they do have more toxicities that may be irreversible.
Thank you. So, are there any other questions from the audience or the faculty?
Hello, ma'am. This is Nishad here. So,
Yeah,
many I have come across many patients who develop thrombocytopenia while being on TKIs. So, how do we manage it? Because it leads to treatment discontinuation. The BCR-ABL, does not decrease substantially. And what is the use of romiplostim in these situations? Romiplostim or TPO agonist?
So I will say that's one of the more frequent consults we get. I mean, thankfully, the prediction that patients wouldn't have severe cytopenias that was made in the late 1990s, early noughts when these drugs first came to attention hasn't proven to be true. But that group of patients with severe thrombocytopenia, I have very many of them. So you can only break the cycle by effectively reducing BCR-ABL. And so consequently, if you keep holding the drug and the BCR-ABL burden of disease remains high, every time you reintroduce the drug, the platelet count plummets again. So I try to use the most potent TKI. Dasatinib may have a little bit more thrombocytopenia than some of the others. But, nonetheless, sometimes in those situations, I'll even reach for ponatinib. Asciminib, by the way, does cause thrombocytopenia as well, so it's not a fix for this issue. I will use L-Trombopeg. I have probably been able to get the drug for about 60 to 70% of my patients. And I will start at 50 milligrams and I'll escalate the dose to 300 milligrams. And the reason I can get away with doing this is that a paper was published by Dr. Cortez at MD Anderson a year ago before he moved to Georgia. And in that paper, they looked at about 15 CML patients, and 9 of those patients had platelet responses and decrease in BCR-ABL and had good responses. Another subset of patients didn't. And so I also have to start TKI dose low. So whatever I choose, second or third generation, I'll start at 25 to 50% of the dose. I start L-Trombopeg. 50 isn't usually good enough. You need to get up to 100 and higher, 150 at least. And then very slowly, I escalate the dose. I am also, perhaps this might be a little cavalier, but I can follow patients very closely. So I let their platelet counts drift down. I watch them like a hawk, as long as they're not, single digits. If they're 25, 25, 25, 25, I just keep going. If you have neutropenia in the same situation, I'll use G-CSF. And what's happened when I'm successful, I have a couple of patients who are now with deep molecular responses, or MMR, on therapy. I've been able to successfully increase the dose of therapy, and platelet counts have mostly sort of normalized, although a lot of those patients will end up living between 100 to 125,000. But if this doesn't work, I send you to transplant, right? Because if I can't treat you effectively with TKI and your BCR-ABL remains greater than 10%, well, you're at substantial risk for disease progression. And so when I fail at this, I transplant patients.
So, ma'am, do you keep a target of 25,000 and stable, and you don't stop the drug even at that point?
Yeah, I agree. You have to be able to follow very closely. It can be very nerve-wracking, and I think this is why I end up following these patients, and they're not followed in the community. because the label clearly tells you that the minute you're like at 50% or lower, you're using nothing. But remember, I'm a lower dose. But if you don't want somebody to have a intracranial bleed because you did this. So I fully acknowledge that this is difficult. And there are patients where, they're 11 and 12 and you just can't do this. And so I have transplanted, and then I have a few older patients above the ages of 75. The older you get, the less cellularity you have in your bone marrow. And in that case, we know that even a major cytogenetic response will bring some benefit in survival. And if you're 78 or 80 years old, maybe that's good enough for you to have good quality of life that's safe. So my aggressive treatment strategy is really for young patients, mainly.
Dr. Vivian, one more question I want to ask you. When you choose the TKI in your clinic, say young patient, 30 years old, low SOCAL score, absolutely fine, no comorbidities. So how do you choose them among the 4 of the drugs?
Yeah. I have to admit, with 20 years of experience with CML at this point, I just only had imatinib. Then I was a big fan of the second generation TKIs. And now that I realize all the problems that happen with second generation TKIs, I'm back to imatinib. Honestly, between imatinib, dasatinib, I don't use a lot of nilotinib in my practice. And the main reason is because I have to suddenly be a really good primary care physician, right? Because if nilotinib causes an increase in heart attack and stroke, I have to make sure your blood pressure is okay, that your fasting lipid panel is okay. And I acknowledge that 50 is young, but 50 is still a person who is going to, over time, perhaps acquire cardiovascular risk. When you look at the decision study, there was maybe a smidge more cardiovascular events versus imatinib. For bosutinib in the before study, we haven't seen that. So bosutinib may have a low cardiovascular profile. So I have started using a lot of bosutinib. I spent a lot of time talking about bosutinib data because it's available in a lot of locations, and it can be difficult to use because of the GI side effects. And so I really wanted to show data about how you could start at a lower dose, escalate for a response, and that way make that drug more tolerable. So I will sit down with patients. If you've got a lot of comorbidities, I'm a big fan of imatinib. I will tell you, I could go either way for this patient, with dasatinib, which I start at 50, by the way, bosutinib, which I'll start at 300 to 400, or imatinib. And sometimes patients have distinct preferences. Some patients love the long-term safety profile of imatinib. So one strong point for imatinib is, I know after 20 years, 25 years of follow-up that nothing's going to happen. So some patients really feel very comfortable with that, knowing they're going to be on drugs longer term. But getting deeper responses quickly and being able to get off therapy faster is sometimes prioritized by others. Yeah. I see we have something in the chat box here too. So I know I haven't directly 100% asked your question. That's like the beauty of CML management in the US in 2022 is there isn't a right answer. Either one of those choices would be good. I might favor bosutinib a little bit in that situation, but I think imatinib is a very fine choice for this low-risk ELTS score patient.
In your presentation, you mentioned that regarding the bosutinib-induced diarrhea, and you used a very strong antidiarrheal agent, right? So what the antidiarrheal agent you generally use in your practice?
Yeah. So I'm okay. I actually find that when I start 300 milligrams, so the problem with the 300 milligram pills actually sometimes in the US is that the price of 3 100 milligram pills is higher than the price of one 400 milligram pill. So you have to make a really good justification. But the best strategy I find to start is to start 300 milligrams because the GI side effects are quite a bit lower. I do this even in patients I'm switching to second line. If you're a person who does not have a very good BCR-ABL response on 300, of course, I'm going to try to increase your dose to 400 a little bit more quickly. But in keeping with the Italian BEST study, I've actually found that many of my patients don't have to escalate. So I have a good panel of 300 milligram patients. And honestly, I use Imodium, for diarrhea and also diet changes. So it turns out if you're somebody who eats a lot of kale or a lot of green, leafy, roughage type vegetables, fatty diets, spicy foods, these are the kind of things that are going to lead to diarrhea. So this brat diet, this really bland diet can really help too. But the starting low and escalating, I think, is really the key, which of course was not done in our studies, which is why you see a huge discontinuation rate, I think, in the ASSEMBLE study. You know, practically everyone stopped bosutinib on that study because of side effects.
Any questions?
I see a question from Dr. Nayak. I hope I pronounced your name correctly. So I have a patient, 34 years old, diagnosed with a woman diagnosed with CP-CML in July 2019, on imatinib at 400 milligrams daily until February 2022, maintained MMR till February 2022. She stopped the drug and became pregnant. She was treated elsewhere. She had 0% BCR-ABL last month, and now it's 14%. All right. She came to me last week, repeat BCR-ABL, it's 3.3%. White cell count, 7,200. Is that the absolute eosinophil count at 700? No blast, no myelocytes, she's 26 weeks. All right. So I probably would I would monitor. I wouldn't do anything here. You have two choices. So one thing, you have three choices. One, do nothing. Two, you can think about interferon. Three, not yet, but I have used imatinib in the third trimester and beyond. Okay, we don't really write this in the NCCN guidelines. There is not a hint of this, but every so often I've got somebody with very high white cell counts who's pregnant with CML all at the same time. And Dr. Drucker and I have talked about this in depth because Dr. Drucker at OHSU has actually managed more pregnant CML patients than you'd think. And third trimester and beyond, we have data from the ELN. Probably the only thing they've seen is a slightly lower birth weight in this situation. That said, the UK have looked at this, and honestly, if somebody has a white cell count that's less than 50,000, or in this case, a complete hematologic response, or platelet counts less than 600,000, and I didn't see the platelet count here, it's probably okay. If high platelet counts can be worrisome for thrombosis a little bit, but honestly, I'll just wait. We don't want to deliver the baby early, obviously, that's no good. So we still aim for 38 weeks still. But I have used interferon in these situations as well over the years. The problem with interferon, it's so slow acting that by the time I finally get the interferon to work, they feel sick from the side effects, and it's multiple weeks in the future. And so in my own practice, and this is again just me, if somebody is in a situation with very high white cell counts, enlarging spleen, symptoms, etc., in the third trimester and beyond, I have used imatinib. You cannot, I wouldn't use dasatinib. It crosses the placenta at a higher rate than imatinib. So in summary, again, with this case, if the platelet count is normal and the white cells are normal, I would monitor closely. Here on a monthly basis is typically what I do for BCR-ABL, although I act based on the blood count and the symptoms. But interferon would be a reasonable choice in this situation. And I know in Italy, for example, if BCR-ABL is greater than 1%, even with a hematologic response, some would start interferon in this situation. I find it generally poorly tolerated and have been less likely to use it. So I hope I have addressed your question.
Hello.
Right.
Hello, Dr. Sanya.
Yeah.
Dr. Sanyal, can I continue?
Sure.
I'm Dr. Naik. Can I continue with the, with the question? I couldn't. Thank you, Professor Vivian. Her platelet count is normal, 1,98,000 today. Actually, she's come back for follow-up today. So her hemoglobin is fine. And what I have planned is I'm going to do a close monitoring on the BCR-ABL every month until her expected date of delivery somewhere in the first week of January. And I'm planning to monitor the CBC at least twice a week to see if there is any increase in count. I gave her the options of imatinib maybe in third trimester, but with risk explained. Interferon, yeah, but it has its own side effects, so I didn't give her an option about it.
You know, it is a safe drug. It's just slow acting and has a lot of toxicities. And so the last time I did this last year in the third trimester, it was like patient's white cell count, you know, within 1 week, you know, went from 80,000 to 7,000. And so, you know, it put her in a good position for delivery. So I would agree with your plan because I would do something very similar in my own practice.
Okay. Thank you, ma'am. Thank you so much.
Any questions from the faculty?
Yeah, Dr. Javed here.
Yeah, please, Dr. Javed, go ahead.
Thank you, Professor Vivan. My question is on those patients who go into blast crisis. What is the percentage of those patients? Though we know it is very rare that there will be mixed phenotype in this crisis. But if somebody does get a mixed phenotype of blast crisis, how to treat that?
Yeah.
Is there any?
Great question. The short answer is I favor a lymphoid regimen, but let me come back to this. So, with CML progression, we got 2/3 myeloid and about 1/3 lymphoid, but we know MPAL is a really, if you see MPAL and they don't have a history of CML, you definitely need to look for MLL and for pH and look for a prodrome. So, the data retrospectively seem to favor that lymphoid regimens first might be somewhat more effective than going with the myeloid regimen first. On the other hand, if the myeloid population is the overarching population and there's barely anything and your pathologist is struggling to say that this is MPAL, yes, I've seen situations where that is. But generally, after talking to my ALL colleague, in detail, we've started to really focus on using hyper-CVAD. I will do hyper-CVAD part, 1A typically in this situation. And for those MPAL patients, you really have to do CNS sampling. And I also favor intrathecal therapy like they do for the ALL patients too. And to support this, there are a few review papers and meta-analysis that also indicate that the data would favor starting with the lymphoid regimen.
Dr. Vivian, the same question and in a little different way. So suppose in the myeloid blast crisis, you mentioned the TKI plus minus the conventional chemotherapy. So suppose in a myeloid blast crisis, you want to use TKI plus 7+3 or TKI plus azacitidine venetoclax combination in today's era?
Yeah. So depends on the patient. So first and foremost, there's been some debate, and not everyone's a little bit different. If you're a de novo blast phase patient and you're older, it's quite reasonable, especially if transplant's not on the agenda, right, to start with TKI alone. However, if you want to get into remission in a timely manner, and this MD Anderson review paper that looked at this, and also data from Europe would suggest that for myeloid blast phase, TKI plus induction chemo is the way to go. And that was intensive induction. That wasn't decitabine and venetoclax. However, in the US especially, many of our patients are quite a bit older, and so they may not be really good transplant candidates. So what do you do to treat? I have actually been using a combination of ponatinib, azacitidine, and venetoclax in this situation. I don't know if it's that great, honestly. I mean, we know that in AML too, right? I mean, you give these drugs and unfortunately they fail and then they're super resistant and you can't treat them. But it is pretty well tolerated, and I have to tweak the doses a little bit, right? The problem with these regimens is patients get so cytopenic. So I probably end up giving the TKI sort of continuously, and then the venetoclax I decrease to 2 weeks or even 1 week because I don't really want them to sit around with an ANC of 0 all the time. And then the hypomethylating agent will be at 5 to 6 weeks. Generally, a lot of people I see for transplant are transplant candidates, and so I'm going to go the intensive induction chemotherapy route. So 7+3 is perfectly fine. I happen to be at an institution where we like to use 3 drugs. So, whether FLAG-IDA, we tend to use CLAG-M. And so that would be usually what I use for induction. And of course, the TKI. Ponatinib is the most powerful one. Certainly, MD Anderson has published some data that you really have to pay attention for cardiovascular events on ponatinib plus intensive induction chemotherapy. And for de novo patients, you could certainly say they've never seen a TKI, so imatinib or dasatinib, of course, is perfectly fine.
Thank you.
Can I ask one more question?
Sure.
About your talk? You said that hyperglycemia is a feature of nilotinib. And then on the contrary, when we withdraw imatinib, some people develop diabetes. Do you know any sort of mechanism? How can we explain this?
I've made the same observations, right? And so for a while, we were just wondering if imatinib was, was somehow protective, but we've never really been able to prove that really. But I think many of us have, you take the imatinib away and you're like, oh, how come your blood pressures are higher? Oh, geez, your blood sugars look a little different or your lipids look different. But for every patient that's like that, I have others that aren't like that. I think I will say that in the old days, before I knew this better, diabetics on nilotinib are kind of not a good combination because it really does mess with their ability to manage their diabetes. And so when I've switched those patients to bosutinib, for example, they've all needed a lot less for glycemic control. And I think at the end of the day, nilotinib, probably its main mechanism for increase of cardiovascular events most likely involves endothelial cell dysfunction of some sort. And that's all I can really say. We don't know much beyond it. For ponatinib, actually it raises your blood pressure almost immediately when starting it. And so I think why we see events is because blood pressures go up pretty quickly. And because in the US patients are quite a bit older, they might not have been diagnosed with hypertension before they come to see us. And then if we add ponatinib, absolutely going to create hypertension. So if you stay on top of that, I think that also helps with the management. For nilotinib, I think, of course, blood pressure control is important too. And then I think for both of these drugs, I don't have great data to support it, but I think keeping optimal cholesterol control is probably important too if you're going to use nilotinib.
So Dr. Vivian, one more question regarding this point. So suppose patient is on the nilotinib or Tasigna, doing very well, and developed coronary artery disease and then stented. So what do you do then? You just continue the imatinib and the nilotinib same way, or you change the drug?
I stop. Yeah. And I think the Australian data really showed that even if you did absolutely everything, stented, aspirin, lipid control, everything, they still had recurrent events. And I've actually seen this in my own practice in referrals. Now, I will say I don't mean to say, I just happen to use less nilotinib because of these issues, but there are some patients who do great on it, and they have no side effects whatsoever. And if you were to put them on a different drug, they would suddenly have side effects. But I just do not feel comfortable. I would never continue somebody who's had a cardiovascular event because they're going to have another one on continued Tasigna. Even I'm going to say, no, we don't have dose adjustment doses. I mean, I know 400 has more of a cardiovascular risk than 300 twice a day. 6 years follow-up for an SND, it was 16% versus 10%. But I can't tell you that 200 or lower is going to be better. So I would strongly recommend a change in TKI in this scenario.
Any questions from the faculty?
I'm Nishad here again. So in your practice, what is the dose of dasatinib you routinely use now with this MD Anderson very promising data coming up?
Yeah, so honestly, most of the time I use 50. And it's often a no-brainer because a lot of my patients are over 60, and I will say almost everyone ends up getting a pleural effusion at some point in the older patient group. It is a great question to what about high risk young person, right? So the data looks great for 50, but on the other hand, you've got two goals in CML, right? One, to give you a normal life expectancy, and two, once you get there, to have good quality of life. So sometimes for my younger patient I saw yesterday, high risk SOCAL score, I start 100 until I know that they're getting to goal, because a 25-year-old like this young man is going to have a much lower rate of pleural effusion with it too. So I will say almost all of my patients are on 50, but for the young patients, and I know the average age of CML onset in India is much younger than I have. And there's also riskier CML in India. So I think starting full dose there is reasonable. And then if they actually get to MMR or deeper responses, you can make a dose adjustment.
Yeah. So any other questions from the faculty?
Yeah, thank you, Dr. Vivian. It was a pleasure listening to this comprehensive coverage of CML. Now, I am Dr. Ravi Kiran, a medical oncologist from Southern India. I just want to know if there is any role of arsenic trioxide with or without TKI.
Yeah. So there is data, 15 to 20 years ago where we explored that. And I do think that arsenic probably has some efficacy, but because the other therapeutic options we have are so potent. It is not something that I have used in my clinical practice. Although their very early work in the CML field did kind of look to see if addition of arsenic, to TKI would be useful in advanced phase or for resistant patients. But now, because we have third and even fourth generation TKIs coming, looking at combinations of a TKI plus asciminib, as well as some other drugs such as venetoclax, haven't been using, don't have any experience using arsenic in that situation. Is it a particular patient that you're thinking about this in?
It's the cost factor. So compared to the modern newer generation TKIs, it will be cheaper.
Yeah. Is imatinib not a possibility for this patient?
In other cases where there is some resistance, primary resistance.
Yeah, I do think if we have to reach, all of these therapies are not cheap, but I think outside of TKIs, probably interferon and mastotaxane are really the only non-TKIs with some efficacy. We just don't have robust data for arsenic, although it probably has some impact because it works on so many different levels. It's a little bit different than APL, where we have a very distinct mechanism, right, of action there, which is a little bit clearer to me than for CML.
One more issue was regarding this principle of anakynosis. So the team by Dr. Daniel Hubolder from Germany, they tried to do this tissue editing and transcription resetting, biomodulation. So is there any role in primary resistance to TKI and in post-HCA allogenic refractory or relapse cases?
This is an interesting question. I would say for us here, what sits on the research front, for the most part, are looking at, my own work in my own lab, we're doing high throughput drug profiling for combos right now to find things that might be effective in CML specifically. I looked at 50 patients and we're about to expand that work. I will say, obviously, I think the whole realm of immunotherapy, I don't know that PD-1, PD-L1 have really had much of an impact in the clinical trials that I've seen. I have used CAR T cells for patients who have had relapse after transplant, but only for lymphoid, because our CAR T cell program is really best with CD19 targets, and our myeloid CAR T cell, and I don't know that CD123 CAR Ts is really that useful. I know in California, they have some data on can we switch microRNAs that are important in CML, and can we manipulate those? And so these things may all be possible, but I think they probably a little bit further from clinical translation at this point than maybe the CAR T cell program. I personally, I know, at least in the US, that blast phase thankfully is infrequent, but when it happens, it's deadly. And so I personally wish we could come up with some better non-transplant therapies, obviously. But at this point, transplant is still the thing that I recommend for resistant with no choices or advanced phase disease.
So Dr. Vivian, thanks a lot for the wonderful lecture and the very lucid discussion. So we actually all hematologists and the medical oncologists are enriched with your nice talk and discussion. So I'd like to thank all the discussions who are themselves very eminent hematologists and medical oncologists of the country. I also like to thank Mr. Dinesh, Lekha, and Rahul and the team Novartis, Mr. Yash and Mr. Kalpesh and the team Perfect Square for the logistics, all the executive members of our Mumbai Hematology Group, and my special thanks to you for this wonderful meeting, and happy Navaratri to all of them. Thanks a lot. And now I hand over the stage to Nildeep, Perfect Square.
All right. Are we still live? you.